Good morning.
Dr. Dangus, Dr. Kinney, how are you? Good morning.
Good morning. Yeah.
Good morning from New York. Dr. Kinney will start up.
Yeah. Thank you for this opportunity, and we welcome everybody there in your society meeting. And we are doing this live case from Mount Sinai. Myself, Dr. Kinney, who is the director of the Cath Lab, Dr. Dangus, who is the director of innovation here at Mount Sinai. I have two of my fellows here and technicians, as well as the nurses of the Cath Lab. Kiski will be our fellow who will be doing imaging. So we can start the slideshow of the case that we have today.
All right, great. Entire team over here. And very happy to do this case in collaboration with Sky Middle East. Why don't you tell us who is on the panel? So while we're presenting the case, we can go next slides, please.
Okay, so this is the case. Patient who has had no significant prior history, who presented actually in August with the first time of angina after having had a positive stress test, which was a high risk for multivessel ischemia. At that time, cardiac cath, which was done in August 13th, revealed that two vessel disease of the circumflex and LAD. So risk factor wise, hypertension, diabetes, hyperlipidemia, and you can see the medication the patient was on. So stress MPI actually showed inferior, lateral and anterior ischemia with the normal EF. So cath had shown two vessel disease. I will show you the angiogram. And then if you see the LAD proximal was calcified and as well as moderate disease. So today also we did the FFR. FFR of the LAD was positive. FFR of the diagonal was positive also. And then patient did have a heart TIM at that time and had a circumflex PCI. Today we are planning PCI of the LAD, which would be imaging. We are going to do OCT, decide how much calcium is there. Based on that, we will perform some kind of atherectomy and then decide how to handle LAD diagonal lesion. So we always make sure the patients follow the American Heart Association ACC guideline, which is OC criteria. The patient, based on the symptoms, medication, the patient is definitely appropriate for PCI. So here we are going to show you the angiogram.
Please. Yes. Let's go to the angiogram. We see that, yeah, very good. LV gram, good LV function. Dr. Kinney told you the RCA not so significant. You can see that very clearly. The circumflex not too bad.
And the stent is patent.
Stent patent in the kind of OM, early OM or high lateral. And that's where we are now in the significant calcific proximal LAD, positive FFR. And we'll have a diagonal coming off. So it's what do you say, Dr. Kinney? What is the what's the Medina classification here? 110 or 100?
Now, angiographically, if you see, we will call it 100. But then, since we have done physiology, which has made it into 111 now. Now, going back to the caudal. How do we make a diagnosis of calcium? Angiographically, if you see here, before we inject dye, you actually can see tramp track calcium in the LAD.
Tremendous. Yeah. All the entire wall. You can see how it goes. I'm going to freeze it right before the dye. Here you go. So you can see now, you can see the LAD, the calcium all the way going towards 2 o'clock. And again, the dye comes in exactly where the calcium is. Tremendously calcific. And the diagonal, very interestingly, the lesion in the diagonal comes a little bit, the significant lesion is a little bit after the ostium, after the TEXA. So, obviously we need to think about that. So we would like to do some imaging, obviously, in preparation of the procedure, and maybe we get a chance to do the imaging and as well explain the imaging via the special app we have here, and maybe present you the chance how to use the app in order to help everyone understand all these OCT imaging pictures. That's what we're going to use. Um, Perhaps while we're wiring and setting up the OCT, we can have some panel discussion from your point of view.
Die.
Okay,
Let
thank
us.
you very much. I have here with me Dr. Muhammad Subhi, Professor of Cardiology, and Dr. Abdullah, Dr. Jassim, Dr. Ahmed. So please, any one of you, you've seen the...
Tell him
the
outside
ankle.
that I need
Do you
more
think
volume
the
in my
lesion
ear.
Is it for PCI? Is it for
It's good. He needs to increase the
further
volume.
Oh, yeah.
test?
Yeah,
Anything
yeah.
else?
Give me
Please.
some die.
George, this is Mohammed Sope speaking to you. Thank you very much for this
Oh,
interesting case, which is usual case. But actually,
yeah.
in most of the centers, you don't have OCT, but here
Uh-huh.
it's 101, and sometimes if you need to have another view to see that's 111. So if you don't
And
have
tell him to
imaging,
fix
you
the
have two
camera. They're
wires.
cutting off our
I
heads.
think we can put the stent, the
Yeah,
LED,
yeah.
This is better.
and then
Tell him
look
to
for the,
fix the
or you
camera.
put a stent in diagonal, short stent, and then do a stent for the LED. That's it. If you have an imaging, it could be the extent of the lesion, which is the importance of this, to extend the lesion either distal to diagonal or the proximal diagonal. That's, so if you have the facility of imaging, I agree. If you don't have facility of imaging, which I don't think most here in the audience don't using OCT frequently.
Dr. Fahad Al-Hajri from Kuwait.
Well, that's why we're going to present also to you the OCT app so they can
Yes,
help
Hani,
you
Hani,
understand the
Hani Radio
imaging
Office.
because that's one of the barriers.
You can ask Hani.
Yeah,
OCT.
Dr. Dangas, Dr. Kenny, thank you
Yeah.
very much. I just wanted to point out to the audience that we just saw an end hole catheter doing an LV gram. And it's something that we are actually in Sky, we're quite against. So hopefully the audience won't copy that.
Yeah, but
Those
let me
with
explain
pictures,
that this is not an injector. This is not a key thing. This is not an injector run. This is a hand injection with about 7 cc's. So by no means to do end-hole catheter and a forceful injection by the machine. Absolutely no. We never do that. Just to clarify again. This is just to give a general idea, but not, not by the injector. Very good point.
Yeah, thank you. I think it's very interesting, but just to one thing, this is moderate lesion to me, so I think having a positive IFR will work on to the imaging for sure, because it sounded very calcified lesion and may need atherectomy for this lesion.
Dr. Jassim.
Great image.
All right, so we did the OCT. We're gonna go live to the OCT. We're gonna do the reconstruction. We have a co-registration as well available in this room, and then we're going to talk a little bit about the OCT.
Yeah.
Okay, let's go ahead. We have our associate here
Cross
deals
filter.
with the OCT with a great result. Go ahead.
Okay, so actually the angio registration didn't work, sorry. So I'll show you from
More loudly.
Okay, so I'll show you from the distal. So it's a start of the pullback. Here is not much plaque, but a little bit calcium like here
Yeah.
at the 4 o'clock, like one
Yeah,
quadrant.
please follow the bottom left panel where the longitudinal aspect of the vessel is, and as he's moving the cursor, and that corresponds to the top right cross section. So you understand where we are.
Yes, yes. So this is the cross section. So here comes a big branch. So come to
So
more
the
proximal.
lumen area comes out to 2 millimeters at the tightest
Yeah,
spot.
yeah,
2
tightest-
millimeters, and now even 1.86 millimeters.
Yeah, and
Square
here is
millimeters.
a lot of calcium like here and here. Yeah, like more than 2 quadrants, and go to more
With-
proximal.
With calcium in like 3 locations
Yes.
around the vessel. And what kind of plaque is this one?
Yeah, this is also the calcium. 3
Again,
o'clock to
tremendous calcium over 180 degrees.
And here the OCT show the tightest, like area was 1.7. And go to more proximal. Yeah, here's tremendous calcium, like here. And go to more proximal. Yeah, not good.
Very good.
Yeah, so here's a big branch, and go to proximal. So this is the left main. and go to more proximal, it's a catheter.
Very good.
Yeah, so I'll show you the, so there's a big difference of the left main and LED.
Very well.
So when I put the proximal reference as the ostial
Very
LED,
well.
like here, and the distal reference like here.
So now you follow the cursor at the bottom left as you see how it moves longitudinally, you get a better idea of what's happening.
Yeah,
And we're going to go to the slides about the app afterwards to understand how the app works and can help everyone interpret these images that are just too many shades of orange, as I say, too many shades of orange. But there is a way to navigate that. You want to go to the slides?
Yeah, they can show the octet.
Let's show the octet slide, please, and a few slides related to this. Go to the slide set. Okay. So,
So this is one of the app which everybody can download. It's free. You have it both on Apple as well as Android. So if you see there, yeah, go to the next.
next slide. All right, this is a OCT case review. It's this is an example of how the app works as a case review or just examples to learn OCT as well as some quizzes at the bottom.
Now, the most important, I understand that you just mentioned many people don't have this imaging, tool there with
the
you
cath
guys.
lab.
But what I meant is, this can be downloaded. One, how to perform OCT. If you have a machine, you can show the next slides there. That you can say how to perform OCT. We show you step by step performance of the OCT. And then more important is you've done OCT, but then how do you interpret the images? So we also discuss how to interpret the images. What is a normal image? What there is a calcific image? How do they look like? All these things are shown in this app.
Yeah, so it's a step by step because in all honesty, we all are a little uneasy about the shades of orange. But this is made very simple by this app, and obviously it's clearly understood that it's not the same as if you don't have the machine, of course. But that's always sometimes people don't get something because they're not sure how to deal with it, and I think that the app helps how to deal with this. And next slide, do you have any more examples about this?
Dr. Kinney, Dr. Dangus, we have a comment here from panelists, if you don't
Go
mind.
ahead.
Dr. Jassim.
Hello, good evening, Doc. It's an evening time there, and we are almost in the afternoon. Okay, my question would IVUS here in this case
Go back to
make any
Anjo.
difference to the OCT you are doing? I mean, what information we are gaining from the OCT in this case can be provided by IVUS?
Yeah, that's a very interesting question, important and a very interesting question that he's asking. Can we do IVUS? Like we mentioned, most people are very comfortable with the IVUS. Yes, we can do IVUS also. What is the difference between the image you have seen is much clearer with OCT. The definition of calcium is much clearer with OCT. So that is the reason I think if you have a OCT in the lab, that's probably a better tool to be used rather than just using IVUS. That's one thing. But can OCT be used? There are some certain cases where OCT cannot be used if the vessel is too small, vessel is too large, creatinine is high. But for the other reasons, OCT is now being done with even without dye. They are being done with just saline injection. So there are things way around it. It is essentially, since the images are very crisp and clear, I think it's better if you want to start using imaging that start using OCT. They actually have a new device where the software will tell you everything, the lesion length, the diameter stenosis, how much calcium. So everything can be automatically presented to you as soon as the image is done.
Yeah, the calcium, the IVUS is essentially blinded by a lot of calcium because of the shadowing and all these things. So, OCT overcomes this. On the other hand, the OCT requires some dye. Actually, we connected to the injector to perform the OCT, injecting 4 for 14 cc's. during the OCT. And again, the newer ways could be without contrast. I think this will enhance the practicality of the OCT, no question about that. And from then on, it's always operator preference. I also heard that the OCT may come in a shade of gray, and it's like IVUS. So we are used to shades of gray, but not used to shades of orange so much. And I think that may also be up soon. So meanwhile, we set up the rotablator because clearly that's what's needed in this long calcific lesion.
So just before starting,
You've seen the imaging. Is it
Yes.
complex? Is it complex? Is it a severe calcification here? You think?
No, I don't think.
criteria?
I don't think so. That's my question to you. Is it this is the shockwave artery, or it's a rota artery? Because it's not a severe calcification.
3 or
It's
20.
a moderate type. If we do the calcification score, the OCT, I think this could be also a shockwave artery. I don't know that it's registered in the United States or not, but actually here in Europe and in our region,
Talked
I
about
think
shockwave.
this is an ideal case for this.
Kiski, can you give us calcium score?
Yes,
So
okay.
we are talking the arc is more than 180, right?
Yeah.
And the depth is more than 0.5 millimeter.
Actually, this part, the calcium arc is from the 10 o'clock to the almost 6 o'clock. I think it's more than almost 3 quadrant.
Good.
More than 100 degree.
And the depth of the calcium?
Yeah, depth of the calcium. I thickest is here. I checked, and the depth was 1.0 millimeter. It's more than 0.5, and the longitudinal calcified length is also more than 10. So calcium score is 4. We need
Yeah.
an atherectomy.
So you understood that?
No.
So how OCT has clearly given a calcium score of 4, which means that atherectomy is indicated here. Now can we do IVL? Yes, IVL is the new kit, and yes, it can be performed here. And
Yeah.
also in this particular case, IVL could be done. If you see there, why? The artery, the lesion, we will be able to take the balloon. So what is the biggest thing that we have seen in cases where it is very tight, 95% lesion, heavily calcified? In that cases, many time IVL balloon does not navigate through that lesion.
All right,
So-
well, we set up with clearly there, when you see a lot of calcium before we even inject, as we said, that is definitely severe calcium. This is a large vessel that with a lot of deep, dense calcium in many areas, over 180 degrees, nearly 270 degrees, 3/4, and a very high calcium score by the OCT. So we set up the rotablator 1.5 Burr to address this lesion as a pre-treatment. And we discussed about shockwave or other specialty balloons, or perhaps you can have a discussion about the drug-coated balloons that are not available in the US but available where you are, perhaps consideration of those for the side branch. That's another thing that is coming up.
I just want to show you the 3 steps before we start. So you move the advancer knob backward, forward. You remove the tension between the Teflon sheath and the bar, and at the Y connector move backward, forward. That means the bar and the wire, any tension is taken away, and then what you do is the bar is already in the proximal LED. Just go on dyna, and on dyna just a small tap. Yeah. So we are ready to burr here. So
Always important to look at your wire where you burn, the distal wire.
pull the wire back a little bit.
Pull a little wire. That's
Imam,
it.
sorry,
Yeah, enough.
Keep going. So we're going at 155
going back to
RPMs
the
per
imaging,
minute.
Since you are expert in the field, will you do imaging? I mean, here, will you go with the non-compliant balloon before you do rotablation? I mean, do you need to do rotablation here, just looking at angiographically, without imaging?
I think I'm going to do rotablation as I did because it's usually better to prepare your lesion before you stuck with the under the deployed stent or
No,
whatever.
my question is, angiographically doesn't look to you severe. It's only the imaging help you to tell you it's severe or not, isn't it? Otherwise, you've not. You could have missed it.
But RCA and LCX before it was
I'm talking about this one, this lesion.
Yeah, I go do
Play.
everything, yes.
So the first burr run did not go through, as you see. The second bear run is going through now. That's another indication that was a severe calcification. Not even 1.5 Burr was able to go with the first run. So that's, you have another secondary verification, if you want, that the calcium was very severe. Okay. That's always good to see. Sometimes
Get
you
me the
think
run
it's
through.
severe, but the rotablator goes straight up. I think we're good
Okay,
after
run.
this
Okay,
run.
come.
So we do
Run
a
through
little
one.
polish afterwards. In the end, in and out a
Yeah,
few times,
yes.
and that's sort of the end of the. Now it's very important how the rotablator is removed. Has to be on dyna all the time, and the second person there pushes the wire while this is the burr is spinning at 60,000 RPM. And then following this, we're going to wire in parallel with a
Advance.
workhorse wire.
Advance the wire.
So, Justin,
Okay.
will you do imaging again now before
Good.
you do anything
No.
else?
Well, yeah.
You want to do
Well,
another imaging run?
need to confirm your
Or after the
results
balloon?
first, before you crossing any. I need to ask question for Dr. George. So,
We'll do
Dr.
it after
George, I have
balloon.
a question for you.
Yeah,
From
please.
your,
If anyone in the panel, please talk a bit
how
more
could
loudly. I don't have that much.
OCP
I cannot hear very well. Maybe I can increase my volume from the control here, please.
Yes, it looks fine and fascinating to have preparation of the region before. But my question is, how
Okay,
could
take a picture.
the imaging system you use, the OCT, help you to choose the modality of a pre-preparation of the lesion? For example, why not
Go.
lithotropy? Why not rotablator? Why not? So why you choose rotablator in the beginning?
Okay, the
I
various
mean,
atherectomy
how
devices
could
that
the
are now
imaging system
available.
help
Don't you
you?
have a calcade?
Yeah, we
Yeah,
don't
let's talk
have.
about
I
that.
don't have that.
Well,
So, which
we explain.
device you want to use? We have another app called Calcificate that can help us to say which app for what. Now, going back to the various atherectomy
No, no, my
devices that are
question.
available, is rotational atherectomy, orbital atherectomy. So, could we have done orbital atherectomy
So my
here?
question
Yes.
is,
Why not? Why not
this is not my question. My
lithotripsy?
question, how could
Could be
your
done
imaging
lithotripsy.
system helping us in deciding what kind of modality we'll use? I
No,
mean,
it
you
is
did
not telling
OCT
you.
perfectly.
Yeah,
We all likes the images.
it is just
We all likes
OCT
the
will tell
images.
you,
So
or
then after,
IVUS will tell you that the severe calcium is severe. Then we as interventionalists have to make a decision, is it rotational atherectomy or orbital atherectomy that we want to use?
Yeah, I mean, in the specific case here, there is no angulation, and in all honesty, any device could be utilized. One could also utilize orbital here, and you could also do the shock wave of the lithotripsy of the proximal LAD. No question about that.
So, Dr. Kenny, you changed the rota wire. Do you suggest to use microcatheter here in case we go into the wrong, lumen or something for the fellows here? Or you just, I know you're expert, but what about fellows?
Yeah,
should they
maybe
do?
initially better to exchange, but maybe initially better to exchange, and definitely needed to exchange over a microcatheter if there is some angulation or some other thing proximally. But over here you see rather straight, no real question for a dissection here. One of the safest recrossings, no?
Yeah.
George, your strategy is to do a one stent strategy?
Well, let's
Because
talk
if
about
you
that
are
now.
going to do two stent strategy, you have to make an OCT for diagonal as well.
Well, let's go. That's
Am I right?
Dr. Professor Sopki jumps in to the next subject now. We forget the calcification and the octade. We go now to the bifurcate. We have another app to decide what's the step-by-step for fixing a bifurcation. We have any slides about the bifurcate? We can go there now and we can have some discussion about what we think. Provisional versus two-stent strategy is obviously a consideration in every bifurcation case. You can see the app that is going to help you step by step how to select by first selecting a left main versus a non-left main bifurcation, as you see on the left side,
is
the
the-
blue or the orange underneath. Over here, we would select the non-left main bifurcation, LED diagonal, and then go step by step on how this is going. Dr. King is going to navigate this.
Yeah.
Go ahead.
Why it's not moving?
So
Okay.
maybe you have a
So
comment
we
from
have
Dr.
both.
Ahmed Khashaba, please.
We have both an app as well as an web app. So we can go to the website, which is called as cardiologyapps.com, where more of these apps are available. Now, whether you want to do left main or non-left main, you can decide by clicking on that particular tab. But then there are important key videos. If you want to understand just to do the various techniques, which includes mini crush, DK crush, culotte. So if you press on these videos, they will show automatically. So here, if you see here, we decided that this is a 110. So we decided that we will do a provisional stenting. So we pre-dilate the main branch. And then you will make sure that there is no plaque shift into the side branch. Suppose there is plaque shift, that's the time you need to make a decision that did you want to do anything to the side branch or no. And if there's no plaque shift, go ahead and place the stent in the main vessel. Now, after placing the stent, if there is any issue with the side branch, that's the time you want to decide how you're going to rewire the side branch. So rewiring also is a technique. So we will take, usually we like polymer jacketed wire, which is a fielder wire to go into the side branch. So if there is a plaque shift, there's two ways you can handle that. One, you can balloon and see if it looks good, we kiss and come out. If it does not look good, that's the time you have to consider that do you want to do a tap technique or you want to do a reverse crush technique.
This is a very important step because people go provisional and people may think, okay, we just put a stent and go. That's not provisional. The more important aspect of provisional is this step to decide are you going to accept the result of the side branch or whether you need to convert and add a second stent. That is the most important aspect of provisional. So go ahead with this either reverse or tap and all that.
Yeah, so that's where we are. We can go back to the angiogram.
Okay, we'll have a comment here from the attendees, Dr. Ahmed.
Yes, actually, coming back to questions
Wanna
of
get
Dr.
the
Gassim, they are very relevant. And
Why
on
the
imaging,
sandwich?
it can decide the modality of the calcium modulation. If we have calcific nodules in imaging, this is in preference of the atherectomy, either rotational or orbital. If we don't have, then we can go for shockwave. Rotational and orbital depends on the size of the artery. If we have a big artery with a deep calcium, then this is again in preferential of the orbital. Otherwise, rota will do.
Yeah, pretty much. At the orbital, you have to be
Anyone
very,
else?
very careful with
Comments,
proximal
please.
tortuosity.
I think let's go back to the angiogram and then we make a decision how we are going to handle this bifurcation.
We're going to first wire the side branch and then do the ballooning, high pressure balloon in the LAD, in the area of the rod ablation. A bit further.
Okay, some die.
Yeah, oops, that's a top branch.
Okay.
Taking the, the diagonal is a little tricky because you want to point upwards to enter it, but then point downwards to avoid that small branch. So, but otherwise, as we said in the beginning, no lesion, but a few millimeters after the ostium, there is a diagonal lesion.
Oh, good. Okay.
Right. Okay, excellent. Now we took this very small branch.
Again, small.
So after you make the top, top you have to make a right, and then you have to go again left to go there. I think we're good. I think we're good over there.
Fahad, you want to say something?
Dr. Dangus, do you routinely image after atherectomy, or you just go ahead with NC and see how it behaves?
I think we have already some information about the reference lumen. So I don't think it's so necessary unless there is a flow limitation in the or something else is happening in the vessel. So over here we're going to take a high pressure balloon by 3.0 and we may consider imaging afterwards or something, but not before. Based on the imaging, we already know and we opened the 3020 high pressure balloon to do this dilation.
Okay, we have another comment, please.
What is the comment? Go up.
No, it's a little frozen, I think, the volume. But they can see the image, so it's good.
14, 16, 18.
Or like 18, 20, go
Yeah.
for it. We go very high. If you hear us,
Okay,
I think we lost your volume, but maybe you hear us. We'll go very high pressure in the proximal, 20 millimeters, 20 millimeter balloon at 20 atmospheres. And essentially, we're going to go a little bit across the diagonal,
up
but
here.
not at 20 atmospheres.
Yeah.
A little bit milder here. And then we decide.
Actually, after rotablator, I put a stent.
Okay, we missed you, Dr. Dangus. We don't know what you did here because it was
Oh,
freeze.
okay. Yeah, me too. Okay, very good. So we did a 23 by 20 balloon at 20 atmospheres in the proximal part, and right after the diagonal at 10 atmospheres. And this is a result here, I think, very, very good, with no obvious dissection and
What was
great
the
flow
balloon?
both ways. It was 3.0 by 20 millimeter high pressure.
I have a question here regarding your balloon size. Are you usually doing one-to-one inflation balloon? On what basis you choose your balloon size?
The OCT was a reference vessel by OCT, remind me?
Yeah, so
So you
the
are
proximal
doing
LED has
one-to-one
3.5,
inflation, right?
3.5.
The proximal LED reference vessel was 3.5 and the middle LED was 3.0. So we sized this balloon after the rotablator to the distal reference near 3.0. And we're getting prepared. If we need to put a stent, maybe we size up to 3.5. We'll see.
Abdullah?
So, Muhammad Subhi, you said you have the imaging is already opened. You should have, done LAD and diagonal. So, if you want to go double stenting or one stenting. Yeah, that's what you meant.
And I think this is I did a short lesion in the mid diagonal. So I have to look either to make an FFR for diagonal to see if it's insignificant, do one stent and see what's happening with the plaque shift. And you can end by kissing or provisional for the second. If you are suspecting some calcium in diagonal, it's another story. So you have to do the same what you did in the left main, in the LED.
Yeah. So I do OCT both ways.
I don't know why the wire was thrown from
We lost the
diagonal.
wire. What happened? We missed that.
The wire was a
Can
little
I ask
entangled with a high pressure balloon. Pulled the wire back a little bit. But again, there is no lesion in the ostium of the diagonal. So rewiring is again easy, but is limited by the many branches that exist here and there.
Yeah, Dr. George, this is Dr. Jassim. I want to ask one question, if you allow me. After rotablating the LAD, you choose to dilate with, was it a non-compliant balloon?
It was a non-compliant
So,
balloon. Yeah.
what make-
Non-compliant, yes, always non-compliant after the rotablator.
So what make you, so my question is, what make you choose the size of the balloon diameter and how far we go up after rotablating a vessel?
So we size the balloon to the distal reference according to the OCT was 3.0. So the
3.28.
proximal reference was 3.5. So we took the 3.0 balloon at 20 atmospheres in the proximal LED segment, and then at 10 atmospheres across a diagonal a little bit in the mid LED segment.
Was the
So-
dissection here expected before ballooning?
Usually you see the dissection after ballooning. Rotational atherectomy would not give that kind of a dissection. No.
OCT?
We have a
Okay,
picture here.
so-
They're saying after that.
Dr. Subhi, if you allow me. So I think for the side branch, this is to me 1-1-0. I would not, image the side branch. With the pullback from the OCT, you can see a very patent, healthy side branch. And also after the high pressure NC, the vessel is clearly patent. So I think this is by all means a provisional to start with.
So stepwise provisional rather than just provisional.
But we are
learned that
we
to
are
be,
ready
to be,
to
to be
see.
dynamic. Depends on what we find. Then we,
So they want us
you know,
to
act,
image.
isn't it?
But we have to see if there is a plaque shift or not.
Okay. So let's take
I
this
think
then.
it's some plaque,
3 or
but it's
28,
not significant.
right? 3 or 28?
Well,
Huh? 275.
Dr. Abdullah, and
No,
I
3
think
or 3
if
or.
you
3
are...
Okay, 3 or 28.
3 or 20. And
we have a comment here from Dr. Jassim
No,
again.
no, I have a question. Discuss with the panelists, not with...
3515.
It's too big, 3.5.
3515.
No, no,
In the
I-
proximal.
because I think the strategy... They can hear us?
Pot. So we plan to go for I think our volume froze a little bit, but we plan to go with a 3.0 by 28 stent, and then we're going to perform a pot afterwards, and we see how the side branch looks.
How many of you will be happy with one stent, LAD only? جزاكم الله خير. Thank you.
Abdullah, I don't think one
Remove.
stent strategy...
How many wants two stents? Just.
Come by quickly.
And somebody there.
How many are suspecting to have ending by kissing with a plaque shift?
So we have to be very,
One,
very
two,
careful that we avoid the crossing the circumflex here. So we have to take another view to make sure we're in the proximal LAD, well positioned, and not in the left main. And I think we are. Let us here to show it to the panel. Looks great. Right there.
Okay, ready? Take a picture. Go.
Dr.
Good.
Ahmed, since you are imaging man,
Okay, good. Go.
we use the OCT also for lengthening of the stent.
okay.
So did we use it appropriately here, you think, and to get that stent?
I think
No.
they
According
used
to
it.
you.
Yeah, I think they used it, yeah.
Let's go the other view. All right, so we nailed the ostium very clearly based on this
How high you went?
view,
10,
and
right?
we're across the
Okay.
diagonal maybe
Go up again once
about
more.
5 to 8 millimeters, which is a
10 is
good
good.
length.
Okay.
I don't think we wanted to go too
Okay,
far
good.
distal after the diagonal.
Okay.
So let's see how it goes.
Okay.
Back
Ready?
to your point, Dr. Abdullah, when we say provisional stenting, it doesn't mean one stent. Provisional means
Beautiful.
you do it and
Leave
still
everything
two
alone.
stent is an option.
Just
We
OCT.
didn't take it off the shelf.
Of the LED?
Yeah, LED.
Okay.
So we're going to do an OCT of the LED now to see if we're well sized or if we need to go even higher pressure proximally. We'll see.
Okay. I think the wire is out again. So much. Of,
It's
and
time
thank
to-
you.
I think you need pot first and then OCT after.
No, it's good. All right, we're going to go the OCT in the LED now. We have about, I guess, about
Give me the
a few more
OCT.
minutes for the transmission. That's great. We're
So
making great
we-
time.
We have still the wire in LED. Do you
Of
really
course.
necessarily need pot now? I mean, you can do imaging without pot. Why you need a pot now?
Or you going to the OCT to show the uniformity of the stent if it's no need for pot or not. This is another story.
Yeah, and geographically, we already look a little bit oversized.
Okay,
So I
guys.
think it's very
Aye, aye, aye.
meaningful to do the imaging because, as you say, maybe a pot is a good idea, but it's not 100% because this stent already looks a bit oversized. So let's see how it looks from intraluminally, though. And the diagonal has great flow. There is no in the ostium of the diagonal. I think at this point we can remove this wire and we decide after the OCT whether we need to rewire or not the diagonal. And anyhow, this
So you
wire goes
remove
behind
the
the
wire
struts.
after pot or before pot?
Sorry, George. Technically, you don't do pot wire. There is a wire in the side branch.
If we do pot, we're
Because
going
I
to have to
noted this here.
reinsert if we do pot, we have to reinsert the diagonal wire. So but right now it's behind the strut. So
If you
Okay,
want to dilate the proximal part of the LED to a different size, you have to remove the side branch wire.
But we
So
don't do this.
we don't do pot with
Is that because of the previous incidents of leaving wire behind or something
Yeah.
new? Because now we do it different. We keep the wire there.
Okay.
yeah, but in the heavily calcified lesions we don't.
Yeah, great image.
So let's see the circularity of the stent,
Keep the wire on.
and let's see
How
now.
many keep the wires in?
We convert into the OCT, please, on the in the cameras. Overall, we see the circularity is very good, but our associate here will give us the small cross sections, and you can see how the simulation exists with the stent very well expanded.
So if you just look at the bird's eye view, you see that the stent is well expanded. You don't see any red dots. If there is a red dot, that means the stent is malopposed. You don't see any of that. Show the stent again.
Yes, I show you the stent. So go back to the distal part. Go to proximal. So this is I show you the distal edge, and go to back and forth. It has no edge dissection and well opposed. And go to proximal. It's all well expanded. Area is looks like more than 6. And go to proximal. Soon the proximal edge. So here is the proximal edge. It's not close over to the left main. And the proximal edge looks like a little bit, but not a major dissection and well opposed. I think it's perfect.
So this dissection, can you educate us more? When is it important?
Okay, so I show you the proximal edge again. So go to proximal. This is almost the proximal edge. Go to proximal. Yeah, we can see that like at 9 o'clock, very small, but I think it didn't.
I don't know if it's a dissection or it's just a little bit of a cleft of the because of the calcium right behind the strut. Let's take another picture.
It's not come to the media and less than 60 degrees.
I wonder if we just see a small side
So
branch
we use
there.
OCT.
What do you think? Could this be the small side branch? Is a small
Dr. Ahmed Imam.
brancher that takes
So
off.
we use OCT post stenting
Yes.
for dissection,
And
apposition,
apposition.
expansion.
Yeah.
Dissection here, when is important? When do you think is significant?
We
So
have
go-
three criteria to choose the significance of the dissection. The quarters is taking from the vessel. If it's taking more than 60% of the circumference of the vessel, it's significant. If the degree of the dissection is more than 40% or 50%, and also the length of the dissection itself, at that time we consider it significant.
Show them
okay.
the dissection flap. That is not important. Go there.
So I don't think fulfills any of this criteria because it's
So let's go back.
it's really tiny.
The dissection there.
Is it
So
a-
what is the key part? The length of the dissection has to be more than 2 millimeter. The angle also is very important, has to be more than 90. None of them meets the criteria,
Great.
which means we can leave it alone.
Has
Yeah.
no criteria. At the same time, I question whether this is also even a dissection. This may be the tiny ramus that takes off and is in parallel with the proximal or the ostial LAD, as disease at the ostium, the ramus, and maybe you cutting a slice of the tiny ramus and gives this impression. So it may not even be a dissection in my mind. When we have another view of the caudal, you will see what I mean. The tiny ramus goes just in parallel of the LAD lumen, and the OCT may pick it up.
So we have 4 minutes to go. Anything else, panelist? يا شباب. Yeah. Dr. Mohammed Subhi, Habibi. Anything else you want to do with imaging, or is it enough at this stage?
I dislike usually to do a balloon following rotaplator, which is almost always you have a dissection after. That's why I'm asking about this. Usually, when to route a
imaging.
1.5, then 1.5, and then go the stent. Almost always have a dissection. You will not cover it, so now sometimes you don't see it. But here, it's not so dissection. It's an intimal flap, maybe inside the stent itself, or just
Yeah, I
proximal. So
think
I will
you-
leave it.
In this view, you can see the ramus. I think what we see as a possible dissection
Yes.
is just the ostium of the ramus.
Yes.
That's my opinion. No dissection. This is just a
Yes, I
funny
agree.
cut of the
I agree, George. Yeah.
ostium. Don't you agree with that? Yeah.
Is there any other way we can confirm this? We can say it's coming from ramus?
I
Using
mean,
imaging. We have imaging available.
if we go back there, you can see that this cleft of the dissection doesn't really have a connection to the lumen very easily. It looks like it's an island outside the stent, so it could easily be part of another vessel, like a small branch.
No, yeah. Not come to the
Okay,
George, the OCT is better than IVAS in detection of calcium and dissection, intimal dissection.
Well, definitely,
Because
whatever
if you do
has
IVAS
a-
in this case,
Yes.
you not saw this.
Yeah, I don't think we would see it. You're right. Yet again, anything that is very close to the interface of the lumen, the OCT has a better quality. Because that's the strength of the OCT, to look at the interface between the lumen and the vessel wall. Whatever happens within that 1 or 2 millimeters around the vessel wall, that's the best case for OCT to figure it out.
Okay, we have a comment.
You know,
Go ahead.
I think OCT is so good that a lot of people, they just react to anything. And this is the time that you should not react to everything. So I totally agree that this is a benign and we should not proceed. Because, you know, a lot of time we see dissection, you don't have to react. Because we do imaging, we will see more. And part of it is to know when to stop.
That was the criteria for dissection. Is it
talk about
important or not?
antiplatelets
As has
and
been
close.
mentioned nicely
Talk
by
about
everyone. So what about
antiplatelets,
now?
we give
Are we
them
going to do a pot
Yeah.
or not?
We don't
No,
need to do
we're
a
not.
pot.
The sizing,
we saw
George.
that based on the,
The
OCT,
missing point is the
vessel,
sizing.
the stent was well opposed.
We're all
Okay,
done.
so no need for pot.
We're all done. This was the final
Yes, we
pictures
agree
that I'm
completely.
replaying them again. This is a completion angiogram.
So imaging
Great,
save you pot.
results.
Can you ask
That
the audience?
definitely imaging save
Abdullah?
us pot. Yeah.
Question, you know,
What
Dr. Davis,
what
what's
kind of
the MLA
medication?
here or MSA?
MSA, they're going to give us a minimum stent area by OCT.
Like 6.
About 6 plus. Is over 6, whereas
How
it
about
was
the proximal
1.5.
part or the ostium?
So beautiful. We have a comment question, doctor. Go ahead.
Just a quick question. It looks like that you've encroached or just crowded the circ ostium. Would you consider FFR in this case?
What?
No.
What?
Ostium of the
Ostium is
LCX.
The ostium of the LCX is unrelated. I can play with that. The stent starts, and by
Model
OCT
picture, yeah.
also, the stent starts after the circ ostium. Circ ostium is angulated, but not bad. Not bad. I would not do
Yeah.
FFR right
Normally
now.
normal.
No. It's angulated.
Right.
That's why
What
many
about-
circumflexes? That's why they call it
What about
circumflex,
diagonal?
because it goes like a circle.
Here. DCB, Mahad.
DCB is a consideration where
The
you
black
are.
chip
We don't have
with
DCB here.
But here we don't have.
Doesn't
We don't
matter.
have. here.
Antiplatelets.
No, but I think the diagonal looks fine to me. You know, I don't think I will touch it unless there was a disease, you know, proximal or something. But otherwise, no. What do you think?
I think the indication to go back to the side branch, which is the diagonal, should be very clear, which is that you have more than 70% lesion visually, which we don't have here, or patient having chest pain, patient does not have any chest pain, or any EKG changes. We can, there's no EKG changes.
Or the decreased flow. So it has none of those. It's a great result from all aspects.
Right. Can I ask up-to-date questions? You know, normally ask people, if you want to know if your stent is being appropriately, you've done the imaging, what about the FFR, IFR here? Physiology. You want to check that as well? To see if what you've done is
No, I don't think so.
No? No need?
No.
So you don't finish your... Why we teach this then? We say you do after the stenting FFR, IFR.
Not an
But here a very good flow, good myocardial blush,
People
good
talk about-
position, no need for
People talk about U of R, O of R, which is combination two together is the whole to get the optimized in everything, physiology and imaging. Dr. Fawaz? Great imaging, yes, I know this.
That is the ostium of
I want
the
that answer.
stent.
Yeah.
Nice.
Oh, by the way, you
If
can
we
see
have time, I
the.
want to ask them about
can-
the stent sizing.
We have 1 minute to go. Just
About stent sizing, are you usually size the stent regarding the intima, I mean lumen diameter versus the medial diameter from media to media?
We size to the media
He's
to
going to
media
tell you.
diameter of the distal, which is pretty much same as the lumen of the proximal. And meanwhile, we have a very good picture right now in the OCT. You can see the opening of the diagonal ostium through the stent strut. We can see by how open it is, completely unobstructed. This is a great image by the OCT. You want to explain us a little bit, and that will be our final comments.
So sensitizing. So first, since by
Thank you.
OCT,
Great.
I check the distal reference and I check the EEL to EEL, and usually we quota size down. So this case is like around 3 point something. So we choose the 3.0 stent, and the length of the size is normal to normal was around 28. So we put the 3.0 28. It's by OCT stent sizing.
So long-term DAPT, Dr. Kinney, what do you think about this case, or just short-term DAPT?
I mean, in this patient,
what's the age of the
high
patient?
risk features, so is ideally
This patient is
has
57.
been on Plavix. Yeah.
so the question to all of us: who will go with long? Raise your hand. Who will go with the short? And short could be 3 months, 6 months, or 1 year. Raise your hand. So all of
So
most would like to go-
why short? What's the indication of
والله
short depth?
حرية يا أخي.
No. I mean, this is the complex PCI. We have stents before in circumference, and we have a stent here, and this is a calcification. This extend the high ischemic risk. So at least 1 year, and then we decide.
Yeah, Mohammed, but you based your things on evidence. Now you have very nicely opposed expanded stent by imaging. So why you are thinking you have a problem with a stent in future? You don't.
It's
I
not
think
in
you
the
should be
score that the
shortened.
imaging
That's the one reason
making a
you
short
shorten
stent.
your DAP, because you have a very good outcome here. I mean, the outcome of stent is beautiful by imaging, and I think by physiology
But
as well.
if this patient acute coronary syndrome,
Is
is
it
the
acute?
indication to make it 3 months?
No, acute coronary syndrome is
Except
different.
high risk of
That's
bleeding.
different. Acute coronary syndrome is different.
You mean
So-
this is the chronic stable angina or chronic coronary syndrome? So your question is chronic coronary syndrome, its indication for short stent, a short depth, in spite of the complex lesion or the high ischemic? Is it questionable?
If I get imaging right, then I'm happy. Dr.
I think we
Dr.
can-
Kinney, Dr. Dangus, your last word, please. Thank you very much for your case sharing with us tonight. So beautiful, step by step. We all learn using of PCI imaging. Please, your last word.
The initial
Want to say something,
comment
Dr.
was
Kinney?
made by people about the LV gram. So I just have to go back to that question that which Dr. Dangus already told you. Yes, we use an end hole catheter which is JR, but it is not by using an injector. It is by hand injection, 5 cc done with our hands. In Mount Sinai, we have done over 300,000 LV grams. We have been doing this over 15 years with no complications. So as long as we know that you have a good LV pressure, there's no damping of the LV pressure like we do any coronary injection, and you do a hand injection, it is a safe way of doing an LV gram.
Well,
So Dr. Hani,
so
Dr.
long
Hani is
from-
actually recording
from-
your
from New York.
what you said.
from New York, thank you. And thanks to Sky for
Thank you
putting
very
us
much.
together and organizing this jointly with yourself as well. We're great to be in Sky Middle East live case session. So long from New York. Great to hear
Thank you
all
very
of
much.
you. We hope to meet soon. Bye-bye.
Thank you. Bye-bye. Take care. Thank you very much. Thank the panelists.